Good afternoon. My name is Matt Hansey. I'm one of the owners of Spruce Pharmacy and currently the incoming chair of the Senior LTC Committee here for PSW. Thank you for joining us for this important session designed for pharmacy students, pharmacy technicians, pharmacists alike. Today's presentation will explore pharmacist provider status implementation, what's working, what's challenging, and what's possible across various practice settings. By the end of this session, you'll be able to describe key barriers and enablers to implementing provider status, compare approaches across ambulatory and community pharmacy, and identify practical steps to align staffing, workflows, and documentation for sustainable pharmacist services. We're fortunate to learn from a fantastic panel of presenters. First is Caitlin Doomer, 2020 graduate from Cordia University of Wisconsin School of Pharmacy, and currently serves as a clinical pharmacist at Lakeshore Community Healthcare, where she specializes in diabetes and hypertension management. Jennifer Hartman is an ambulatory pharmacy manager overseeing Freighter Health's system-wide anticoagulation service and anemia service. She is the past chair of PSW's Ambulatory Care Advisory Committee and a member of the PSW Provider Status Implementation Task Force. Amy Mallon is the Ambulatory Pharmacy Program Coordinator and PGY1 Community-Based Pharmacy Residency Program Director at Aurora Healthcare, part of Advocate Health. A graduate of the University of Wisconsin School of Pharmacy, Amy is actively involved with PSW through the Provider Status Implementation Task Force and is a past member of the Ambulatory Care Advisory Committee. Jordan Spillane is the Director of Ambulatory Pharmacy Services for the South Region Freighter Theta Care, where she leads innovative care models and technology solutions to support community health. A graduate of Purdue University with residency training at Northwestern Medicine and Jesse Brown VA Medical Center, Jordan is an active leader within PSW, currently serving on the board of directors, and is recognized for advocacy, leadership, and passion for supporting women in pharmacy. Rachel Whitesett is the Clinical Service Manager and PGY1 Community Pharmacy Residency Preceptor at Spruce Pharmacy in Green Bay, where she oversees a wide variety of non-dispensing services and leads efforts in medical billing for pharmacy. A dual PharmD graduate from the University of Iowa and 2024 Wisconsin Distinguished Young Pharmacist of the Year, Rachel is passionate about innovation in community pharmacy and precepting the next generation of pharmacists, and one of my most beloved concepts. Supporting the team of speakers is Carrie Traps. Carrie is the Senior Vice President of Practice Transformation for the Pharmacy Society of Wisconsin and has led the Wisconsin Pharmacy Quality Collaborative, WPQC, since its inception. A University of Wisconsin-Madison Pharmacy graduate and PGY1 resident alumna, Carrie is recognized nationally for her innovation in community pharmacy, quality, and plays a key role in advancing pharmacist provider status and public health initiatives in Wisconsin. Full bios for each speaker and facilitator can be found in the conference app. Please join me in welcoming.
Okay, just testing the mic here. Does that work okay? Thank you for that introduction. I am so glad to see so many people here. I'm hoping this will be a really informative session on provider status and lessons learned. As you heard, we gathered a panel of experts that are going to offer their perspectives on their experience with provider status. And we're going to start by having each panelist spend a few minutes providing an overview of their work location and the provider status work they've done to date. And then we'll follow up with some questions that I'll ask the panel, and then we'll open up the mic for anyone in the audience. So if you have some questions that you're burning to ask, we'll definitely have time for that in a little bit. So to get started, we're going to start with Caitlin, and she's going to share. I can advance these as you go. So, perfect. I should start by saying we have no relevant financial relationships to disclose. Okay. Sorry. Also, one more slide. And here are the learning objectives for today's session up here on the screen. Okay, now go ahead, Caitlin.
Hi, my name is Caitlin. I'm a Lakeshore Community Healthcare. We are a federally qualified health center, so in the communities of Baird, Sheboygan, and Washington. We have three 3 on-site clinics in Milwaukee and West Bend. We have 2 pharmacies at each location, and we serve our West Bend community by doing mailing for them. We have medical, dental, behavioral health, and these services on site at 3 locations. We really try to encompass it all, everything for our patients who need, everything but I'm sure this for everyone's health. We have 3 full pharmacists and on our staff. We have our director, myself, and our pharmacist, and that we rotate between the 2 sites I have. And then we have 3 full-time technicians and a dentist that also help out with some of our pharmacy services. And then about 60% of our clinic is, we serve Medicaid patients and then split the other half with commercial and patients as well. And some of the services that we provide is bubble bathing. We don't have over 100 patients right now. And we have revamped systems to make it super easy and less stressful for us inside the pharmacy. And we also do diabetic and hypertension counseling with patients. We meet one of the patients inside our clinic to review their bad readings, just to help them optimize their health. When we do billing for time-based codes. It's just what we found to be the easiest. So between up to 15 minutes, the 16 to 29, and then 30 and up. We do most of our visits with patients via telehealth. There are patients who we understand that health isn't the greatest, whether it be a language barrier, or anything along those lines. We have them do patient visits. Some of the steps that where we're at, we are currently billing for all the Medicaid. So that's been a really great bonus for us. So we're just trying to optimize that as much as we can to bring in some the. And then we don't have the return on our information quite yet. We're still very early stages. I'm collecting that information. We're very excited to see how that helps improve. Some of the lessons that some of the biggest challenges for us was connection, which we'll talk about later, and some of the community healthcare rules that we have to align with. And then some really great things that have is getting our providers to buy to the services that we can provide. We're getting those things.
All right. Hi, my name is Amy Allen. I'm an ambulatory clinical coordinator for Group Health, which is part of the Advocate Health System. I'm also the co-lead for our provider status implementation teams, along with Jennifer Cody. And then we had a lot of help this year from Megan, who's our past BDI1 community resident. This was part of her residency year. We currently have 8 clinics that are live with provider status at our St. Luke's and Sinai Hospital locations in Milwaukee. 7 of those clinics are considered hospital outpatient department clinics or HOD clinics, and then 1 is a true ambulatory medical group. We have 17 pharmacists that are currently enrolled as Wisconsin Medicaid providers. And then we also have 3 pharmacists that are currently in the process of enrolling, 2 of our new PDY1 residents, and then 1 of our new pharmacist hires. So very excited about that. At our 8 clinics, we provide chronic disease state management under collaborative practice agreements for a variety of disease states. So our anticoagulation clinics are part of the pilot. Our chronic disease management clinics, where we provide disease state management for diabetes, hypertension, hyperlipidemia, and tobacco cessation. And then we also have several specialty clinics involved in the pilot as well, including our endocrine clinic, heart failure clinic, cardiometabolic clinic, and our pulmonary clinic at St. Luke's. Because we have 2 different clinic types that are involved in the pilot, we're getting guidance from 2 different billing and coding teams. So our hospital outpatient department clinics have hospital employees that are seeing patients, and so we're billing facility fees in those spaces. And then in our ambulatory medical group clinic, we are dropping professional codes, so the E&M codes, either based on time or medical decision making. And we were very excited to go live. So just over a month ago. At the time that we submitted these slides, we had already submitted claims for 58 patient encounters with our pharmacist as the billing provider. And just earlier this week, we hit over 100 claims, which was really exciting. Our biggest challenge so far has been getting to the point of implementation. So we are a very large health system, and we had a lot of different stakeholders that we had to work with to get to the point where we could go live. We had a lot of help from our informatics colleagues, both within pharmacy and outside of pharmacy. We also had to partner with medical group credentialing, contracting, hospital billing and coding, professional billing and coding, revenue cycle, finance, compliance. So we had a lot of meetings with all the stakeholders to make sure that everyone is on the same page about implementation timeframe, barriers that we're coming up on. And then we also had specific meetings with each stakeholder as different items came up that we had to assess. And then since we've gone live, our biggest success has been we've increased access to patient care that we previously didn't have the ability to give them. And then because of our new partnership with the medical group credentialing team, we were able to devise a specific workflow where our pharmacists are now credentialed through the medical group when they're billing providers, the same way that our physicians and aides.
Right. Once again, that's from region, and I'm going to kind of care clinic because that we have chosen to focus on with the primary care clinics that are associated with our physician and medical group. So kudos to Amy and her team for doing it in both places, but we decided to make one thing easier and just focus on physician clinic space rather than trying to also understand how to go accurately and compliantly within the hospital-based departments. So in our region, in the primary care space, we have over 1 million clinic visits with providers in the primary care clinics. We have over 35 primary care clinics and about 300 physicians and close to 300 PAs again focused on primary care. And then within our primary care team, we have 19 pharmacists, and they are all credentialed as providers with Wisconsin Medicaid. And then we also have 3 nurse educators. So these pharmacists work through collective practice agreements to optimize patients' medications, but also provide disease state education, lifestyle modification. Then once patients are close to being optimized or optimized on the medications, our nurse educators help with getting them to that final dose or with additional medication. So hard to believe it's been almost a year. We have gone live. If any of you, we could have gone live in July, maybe more. We had just a slight delay because, like Amy talked about, also a large integrated health system. And so it did take some time to understand who needed to be involved in the implementation of this process and just everything that goes behind the scenes with the electronic health record and billing. The question that we get asked most frequently is what are the codes that your team is frequently billing? Because if you have looked at the list that Medicaid provided us, you will be scrolling for a while, which is cool, right? But it's a little bit challenging to narrow it down. So we included billing codes for the office visit, video visits, scheduled telephone encounters, continuous glucose monitoring. Less frequently, smoking cessation and technique in self-management and blood pressure, but that's purely because of so it's not necessarily the same for the organization. And then what has been an awesome thing for us, again, being in a health system, is now we have pharmacists that are bringing in direct revenue to the organization that is basically the same as how physicians and ADPs bring in revenue to the health system. And so finally, finance and I are speaking same language. And there's just been more synergy really between finance and ourselves. And I think that they're understanding some other value that nurses and nurses are bringing into the system, but this is very much helping with that. So our biggest challenge was really determining our project team. I was shocked at how many people are involved in billing our cares. Some were very obvious and others were very much behind the scene. Also, we had the added challenge that there are some billing and billing compliance folks who work for the Medical College of Wisconsin that we needed to recall. So I knew they existed, to be honest. They did not exist. But we were all able to quickly get to know each other and work together. The other kind of fun part, but also challenge, was continuing to explain to all these new team members the role of the ambulatory pharmacist. So many people think about, their pharmacist in their retail pharmacy, and they were having such a hard time understanding why we would be billing this continuous glucose monitoring, for example. So, great that we're continuing to increase awareness of ambulatory pharmacy and what all pharmacists are trained and able to do, but could be a little bit frustrating through the process. And then I don't know if this is going to happen January 1st, but this January 1st, there were some changes with billing codes, and I have to give a shout out to Hannah, ambulatory pharmacy manager, who's done an amazing job with implementing and optimizing this process. She tried to be proactive. She reached out to everyone that she knew to reach out to make sure that we were still going to be billing appropriately. And yet in March, we realized that our monthly bill charges had drastically dropped. And it took actually 2 more months for us to determine finance that there was one little thing in this complicated process that did not get changed by someone. And so that was causing all the charges to actually not be sent over to Medicaid. So we were able to fix that, and then they like so much pain. To tell everyone that it's not going to continue to look like that. But, I think that that's just a good reminder that when you implement something as large as pharmacist provider status, you are not done once you implement. You have to continue to study and optimize. And then I think our biggest success is obviously that direct reimbursement. Medicaid only makes up 10% of our patient population, so I'm definitely paying for all of these pharmacists and nurses with just the regulated provider status, but it is more than 0, which I agree is what we need. So that is definitely a positive. Well, hi, I'm Rachel. I work at Spruce Pharmacy. We are an independent community pharmacy as well as long-term care pharmacy in Wisconsin. So we have one location, shop to assist pharmacy resident, local pharmacy students throughout the year, as well as 2 nurses on our team, and technicians as well. So we do have quite a big Medicaid population. A lot of our patients are either primarily Medicaid or eligible Medicaid. So for us, it's really wonderful because it's honestly the vast majority of patients are able to bill under that as well. And one of our main services that we talk about is the long-acting injectable medications, and that is about 90% of those patients. So for services that we want to bill for, we do that. So for most of the services that we provide, we have been actively billing since 2024. We started with medication administration service we've been doing for quite a few years, basically for free. So we started with that. We're also doing mostly a lot of P&M codes and other pharmacies that might look a little bit different in the community setting. So that we're still using our basic CMR codes, the WPQC program. And then as well as doing new patient appointments, and then as well as marketing and chronic disease state management, even at the pharmacy counter as well. And then we're getting into a little bit newer, the vaccine counseling, device education, coaching, using some of those preventive medicine codes, trying to get into some of the more disease focused ones, such as SMBP or CPF codes as well. For us, we've done a little bit back, we were at max capacity for all of our business. This is like an ambulatory clinic, we were full everyday patients, we actually couldn't get them, to pay for parts the same full-time technician to support that as well. And then this has also been, the opportunity to see more patients. So we've been doing the enlargement of the PUC, but there are quite a few more patients that don't qualify. And they have quite a lot of medications, just not in specific states that are covered. Done an opportunity for something to serve them as well. And then for some of the biggest challenges, similar to some of the other places, just slow contracting process. We did all of our credentialing in-house. Just think about cutting your back on some of the HMOs. Even a couple months to get a contract and a couple more months for it to be signed and really take an effect. And then we've also gotten some rejections from our HMOs, doing cycle management in-house in our team. So then looking at what those projections are, looking closely with Carrie and the team at PSW, community pharmacy, in the state to figure out what to do with those projections as well. And then also for us in the technology, we have a dispensing system. We've had ways to do track this, but we don't have nice epic like a lot of other people do to just be able to hit submit to go. So we had to get a new technology provider, figure all that how we can efficiently. So our biggest successes, just getting paid for what we're doing, been providing free services. So just finally being able to get paid for that. And then also the opportunity to spend more time with patients and expand our services. This is our pharmacist's favorite part of to get to be one-on-one with the patients. And now that we actually get paid for doing that, it's really important to be able to do that.
Okay, thank you. So now that we have a little bit of a background from each of the panelists here, I guess it would be nice for us before we start asking some questions to get a show of hands of where the different areas you are all working in and kind of where you're at with billing. So show of hands, we have some health centers here and a community setting, federally qualified health center. So how many of you are here from a community setting? Okay, anyone here? How many from a federally qualified health center? Okay, a few of you. And then more of a larger hospital system? Okay, all right. And how many of you are already billing or started billing? Okay. And then how many are here because you're hoping to start or you're in the process? Okay, great. That helps us sort of as you're answering questions, give us a little bit of background. Okay, so I'm just gonna actually, just as a reminder, so you have your panelists' names up here. I'm gonna start today just asking some questions about how the panelists here got started with the process in their settings. So Caitlin, what preparation steps and considerations did the pharmacy team need to make at your setting to get approved to move forward with billing?
So originally it was just 2 customers this we had, and then it's easy to hire on the systems that cover the so we know at least one day that it was paid, so they put in the back of their minds. But really to convince that basically we showed them encounters that previously been doing versus how much we've been paid for those encounters and never really got that from them. As to why it's important to restructure or students meeting. We also did the PSW credentialing, and that's very informative for us as well. It's getting everything all started and getting them all.
Amy, what were key steps you had to complete at Aurora Healthcare Advocate Health to prepare your pharmacist to start billing as Medicaid provider?
Yeah, so I mentioned we had a lot of stakeholders internally and they had a lot of great information, but we didn't want to overwhelm our clinical pharmacist with all that information. So our project team, we tried to create some educational tip sheets to condense a lot of the information. We had some EMR workflow changes that we had to put in place to be able to list ourselves as the billing provider. So we had some tip sheets related to that. Jordan also mentioned that if you look at the full list of CPT codes that Medicaid will allow us to bill, it's very, very long. And so we tried to distill that down into a tip sheet of the most common codes that we thought we could be charging based on the services that we typically provide. And then we hosted training sessions, so some small group training sessions with all of our pilot pharmacists to go through the workflow changes, the common billing codes that we would be using. And then we assign them some practice patient cases, not from a clinical perspective, but we looked at it from an operational perspective. So they looked at an anti-coag visit or a diabetes visit, and we asked them, what are things that would be required within your note for this visit from a documentation standpoint? What charge code would you use? And then what buttons in our EMR would you put to make sure that you were the billing provider? And then after that, we had a couple of office hour sessions that people could come and ask questions, make sure that they felt confident heading into the go live.
Jordan, was your experience at Theta Care Health similar to Amy's, or are there differences you can share?
Very similar. The other thing that we did after and so we were able to have some ability to 10 patient chart every month. And then we also, and then that information would go back to Amanda, manager, and she would review to make sure that she agreed with kind of the assessment of the billing specialist, more like a clinical perspective, and then provide any education if it was needed to the pharmacist and potentially to the entire team. It's different, right? I mean, it's like we've been billing facility fee, but the documentation and the processes that have to be followed for this billing, it is more than what we had previously expected of the pharmacist. And so really trying to make that as efficient and simple as possible was important to us, and also part of the reason why we have to play with that.
And then Rachel, can you add anything that might have been different for you at Stru's?
Yeah, definitely. I think that was probably similar on a smaller scale for us. So our implementation team was mostly just myself and clinicians. The division I talked to our finance office on is that we then utilize some of our patient forms, and we did use some of the learning stuff from PSW, and also through our community pharmacy and services network. Has a lot of education resources as well. Very helpful and answer all of our questions that we have. We also focused first on the services that we had been doing. We did have some education sessions with pharmacists to go over how do you actually document this now, because we've been doing service, but how do you write this in a way that's stable and medical audit and support the goals that you're choosing to bill for that. And then as well, it's a technology provider. We haven't figured out there are some claims we can submit directly that we have to submit through this other technology provider to be able to get to there. So we did a lot of research on how to actually submit the claims to get that to go in as well. And then for the service that we already doing, we just streamlined our documentation as well. So it's very functional pharmacist to make it extremely easy to fill it in and be able to do a lot of check boxes, and then just having them for to like report write their notes as well. So just making it as easy for pharmacists as possible to do this.
So in the intro slides, you each talked about some challenges and some kind of benefits and challenges of the process. So I'm going to stick with you, Rachel. What do you feel is unique to the community setting in terms of implementing provider status infrastructure? And what advice would you give to other community settings as they prepare?
Yes, sometimes it's fine. Great things over the past a little bit. You just trust them and see how it works. So instead of having to talk to one of the people in the organization, we had to talk to as well. But because of the smaller things, it's a little bit less familiarity with the entire process, especially the management side, the implementation side. we had to do May for that as well, the other community pharmacies that also done this. And then we also have to appoint a technology vendor for them, so just a lot of learning, for any community pharmacies, is very versatile, so make sure that as much as you can, and the PSW certificate programs, it was very good in a lot of things.
Jordan, you touched on this, but you have a large department of pharmacists. Can you describe in a little more detail how you decided to implement provider status billing?
Yeah, this was one of our. We have like 2/3 of our pharmacists in space and department, and the physician medical group, and we talked with our billing and compliance and intelligence billing and compliance folks, and it really was going to be very challenging to bill as credentialed Medicaid providers in a hospital-based clinic if you were also employed by that hospital. It can be done. Amy's gonna show us. It can be done. But it's a lift. And so what we decided was, let's move forward with the physician medical group, which also meant let's move forward with one credentialed entity for and then let's understand after that first year, what are billed charges, and then what is the true reimbursement to the organization. And then compare that to what we are seeing with facility fee billing for patients with Medicaid, and truly understand, is there additional value to the organization for us to more complicated process in the hospital-based departments. So just made one thing a little bit easier, but I'm also very intrigued to see what the true have to be. So I'm excited that we're almost a year in.
Well, Amy, then you get to go next as you're preparing for the provider status. What was the difference you had to understand between those HOD hospital outpatient department clinics and then the non-hospital ambulatory clinics?
Yeah, well, I don't know if we have it figured out yet, but we do have the two different types of clinics. So the hospital outpatient department clinic, we have spaces, and we are dropping facility fees for those patient encounters. So when the facility fee is dropped, it's based on the amount of dropped patient care time that you're spending face to face with the patient. In contrast, in our ambulatory medical group clinic, where we're also piloting, that pharmacist is able to drop professional EM charges. And some of that could be based on medical decision making. We generally are doing time. And the time that she's able to base that on is total time spent related to that patient encounter. So it would include direct patient care time, but it could also include some pre-charting and documentation time. And so we had to call that out in materials when we were having those tip sheets put together related to charges, so that it was really obvious, depending on the setting that you were in, which codes would apply in which scenarios.
Okay. And then Caitlin, what do you feel was unique for implementing your provider status for Medicaid billing in the FQHC setting?
We're going to them. So we have to, think about it. Do we really want to start charging everybody? Maybe we just keep this as a free service that we're providing to people. But then just based on our patient population, right, that's in case on Medicaid, it's really hard to open that. So we decided to start for everybody. We came up with a key system. It's very, very cool. That's fine. But it's all based on and that's what it's important to our patient population because we share low income patients, and so we really want to make sure that it's not a bigger group that has us.
Okay, I'm going to ask another set of questions on credentialing and privileging. And we got together as a group of panelists and we thought the credentialing and privileging words are confusing. So we thought pulling up a slide with some definitions would just help everybody even if you're familiar, just make sure we are clear on what we mean. So credentialing is the process of verifying a pharmacist's qualifications, so their education and training. And that's something HR would use to confirm that, let's say, if you're a pharmacist, that you are indeed someone who went to a school of pharmacy and have the appropriate license. And then privileging is the process of granting permission to a pharmacist within a health system to perform specific services. So this is something an organization uses to make sure someone, a pharmacist, for example, is competent to do the work that we want them to be doing. So knowing those definitions, or just a few questions on credentialing and privileging. Jordan, what was the credentialing process at Freighter Theta Care Health?
So before pharmacist provider status, the credentialing process was essentially what you just, HR ensuring that a pharmacist was licensed and in good standing. And then from a privileging perspective, as an organization, we took the stance that our collaborative practice agreements count as privileging, and then we have a peer review process that allows for us to periodically review pharmacists, their patients' charts to ensure that they are following evidence-based medicine, that they're following the collaborative disagreement guidelines, and that they are working within their scope. So perhaps you're getting it that I like to work. So I took the stance with pharmacist provider status that we would basically continue the same privileging process. With credentialing, we just had to add that all the pharmacists would go through the credentialing committee process. And that requires the pharmacist to have their CV and a few other documents put together and submitted to the committee. And then that little bit of extra work actually helps us quite a bit in the health system, because then we have credentialing specialists who are doing that more complicated contracting, and also the following process to have this become credentialed with Medicaid. So this doesn't actually have to do any of those steps. So it's basically organization. And I'll also plug that as part of the provider status certificate program, there is an excellent presentation on credentialing and privileging. Some wonderful people.
Amy, same question. How was it different for you at Aurora Advocate Health?
Experience the we traditionally have credentialed and privileged our clinic pharmacists through our pharmacy department. So we have a credentialing and privileging committee that is across our Wisconsin and Illinois divisions. And in order to operate under practice agreement, our pharmacists submit their credentials. Those are reviewed by the committee. And then we also submit notes for peer review. So then based on the recommendations of the peer reviewers, the committee will decide whether or not to grant privileges to use the CPA. We continue that with all of our pharmacists right now across Wisconsin and Illinois, but for our provider status group, we also have gone through medical group credentialing, which is owned by the medical group for all of Wisconsin. It's the same for hospital and the clinics, and so that was nice because it was one committee that we had to work with. But one thing we realized pretty early on in our provider status journey was medical group credentialing for our organization is kind of the gatekeeper for other pieces that you had to do in order to start billing. And so we had to lobby them to get added as a billing provider. They already credentialed our physicians, our APPs, occupational therapy, acupuncturists. They didn't want to take on pharmacy. So we lobbied them and they did agree to add us. And so because we were able to get credentialed, that then gave the contracting team the okay to contract and get us enrolled as Medicaid providers with the different Medicaid HMOs. That also gave the okay then for our informatics team to make changes in the EMR so that we could actually be listed as billing providers with our NPI numbers. They weren't willing to do that until medical group credentialing actually accepted us as providers, and so that was a key step.
Thank you. Caitlin, you indicated credentialing was one of your biggest challenges. What made this so difficult and what suggestions do you have to make it go smoothly for others?
Which I think I could. Great. It seemed to have taken a while for us to get credentialed to verbally. Hey, I knew it was get straight last thing to go through, very movie for us, which is great. There's those agent roles that we just go on and get through. I don't know fully what can make it better. But patience.
Rachel, was your experience similar at Stru's Pharmacy? Anything special to add for credentialing in the community setting?
Yeah, so credentialing is pretty similar. We ended up doing all of our in-house, other outside company, which was no one technician that is very familiar with forward health and on the DMA side. So we're able to get the treatment very easy. We then focus our efforts on the HMOs that are most common patients. So we started with United Healthcare and more there. And like I said, yeah, it takes to get contracts back. There's so many email back and forth with basically just waiting for contracts for us so we get sort of billing. We haven't submitted in the meantime. Just in case they decide they want back pay us. Everything's out there. So we did have one that did reject our application. We put pharmacy or we put on there, but they just weren't familiar with what we were doing. So we kind of had to change the number wording to say like medication therapy management to make it more clear on what services we were providing to their patients. And then as far as privileging, I'm very appreciate when I got next. I've been trying to figure out what we want to do for our privileging process, so we don't necessarily have it right now. And that's something we're and we got most of all of our courses kind of credentialed at the same time. But I did pharmacist and another one to get credentials, so we're figuring out separately and into our contract. Instead of just together.
Thank you. I have more questions I can ask, but I do want to take a moment to just open up the microphone. I can keep asking some questions, but if anyone has questions, feel free to come up and then we can take those questions in the next 10 minutes or so. So think about if you have questions to ask. I also want to take a moment to just point out, a couple of you mentioned that certificate program, which has been a lot of great minds worked on that together. So that's a really wonderful resource. I know many of you mentioned. There's also PSW does have a provider status email blast that they send out. So if you're not seeing that specific email, that's something worth getting signed up for, and you can find those resources on their website. So again, don't be shy, come on up. There's a microphone up here. And if you have questions, don't be shy and come on up. And in the meantime, I'm going to ask one more question while we wait for people. Okay. Caitlin, were you surprised that your providers were on board with the pharmacist provider status? And how did having them on board make it easier for you?
We already have a really great vision with to make us as a resource and a tool. So getting them to buy into us also being provided is easy. And we also utilize them when we were leveraging our C-suite too, to get us on board. But otherwise, just making sure you have that foundation as you're set up specifically.
Yeah, come on up.
Thank you all.
Oh. Oh, no, I don't think it's on. Try again. Is there a... And they're recording.
Could you speak to some of those talking points that will be successful in lobbying to get? Sure, I'll repeat the question a little bit for those who couldn't hear it. So I think the question was, what did we use points to get better credentialing to add to their team? We had a really great advocate from one of the contracting teams who kind of coached us along the way of key things to say. She talking about these are services that we're providing and we're just missing out on reimbursement, and that was
really a key thing that we honed in on from that standpoint. She also the other groups that she knew were already credentialed through the medical group that were non-physicians, so chiropractors, acupuncturists, occupational therapists, midwives, and we were just as appropriate for them to start billing, and so we kind of used those as big points to be able to get added to that group. But even when they agreed to do it, we still had to work with them to make tweaks to the application. They had never credentialed pharmacists before, so we had to have them add Form D to the drop down of credentials so that we could actually fill out the application correctly. Make sure that they had the correct pharmacy schools to pick from when we were submitting the application. So there's probably more things that we'll have to edit over time, but that was definitely one of the things, is making sure they saw us the same way that other providers evaluated.
Okay, keep coming up to the microphone if you have questions, and I will, is it working? Oh, good, thank you.
I've been pharmacy manager. Mostly just had a question on the billing cost and everything. Is there some kind of like that shows what the reimbursement is so that we can present that to upper management, see what that really looks like?
Can you repeat the question? I'm not sure that's still, is that working still? Could anyone hear that question? I don't think we can. Okay.
Yes, this list of codes. Yes, I mean, has the reimbursement and the reimbursement, yes. So this is the whole codes that would cover, which is the list, that. The easy way to go on, I just go over the fee schedule on the main page, you get fee schedules. You go in there, you type in, you're on the interactive fee schedule, you type in the code, there's the like search right next to that, so you hit that search, then you have to search again on the button. And then we'll link. So Pharmacist or provider type 23. So it can be a little bit confusing to look at, but you want to make sure you have it under your allowed provider, is that 23, like it's actually 0. And then that will tell you what we get paid. It's usually exactly of what the physicians get paid, so pretty much in line with our other advanced practice programs. But it'll be listed. Asterisk to what you said is also based on your contract with Medicaid and HMO, so just keep that in mind when you're presenting the disease.
More asterisks. There is also a great resource that the Ambulatory Care Advisory Committee put together. That's kind of a short list of billing codes that are probably going to be used in like a pharmacy setting or a clinic setting, and they have on the rate specifically. I think John's holding up the great resource on the PHW website.
So one of the issues that I've been experiencing, we are credentialed this first. We are there. And we are billing, our billing codes have not been going through, a lot of them have been denied. But aside from that, patients are not getting billed. So you mentioned like your fee for service that you came up with. We were under the impression of being told that we have to treat each patient the same and everyone has to be billed the same. But is there a different approach that is being taken with like patients with MA that just any difference in billing, I guess?
Yeah, so what companies can do, and some QHCs that I talked with, is that they'll eat that cost, so it's like still charge the patient, but then the company covers that charge. It's an option. But otherwise it's just you keep submitting, or you wait and see if you're active, that everything's going okay.
And all that, and so yeah, we've had one name say okay, so we would target patients, and we've also been telling them that so CMRs have been covered 3, that was $3. There's also it's changing the mindset since they were billing for a service. It's also changing the mindset of the patients in that we're meeting with a healthcare professional, with a pharmacist. This is not just coming and asking questions. You are receiving our doctorate level service here, so that you're going to get charged just like for that.
We also created an information sheet that we can meet with all of our first time patients, and then we have to sign it. Standing, there may be a chart if they fall into those other categories. And then also showing up what it would be to, what the cost would be to see a medical provider versus seeing AED. So seeing that difference is ginormous.
Yeah, so 2018, I thought this was gonna be a bigger deal for our organization, but essentially we've taken the stance that we could bill these codes to commercial payers to Medicare, but it will never get reimbursed. So, with that in mind, basically we were told that we could have one process for Medicaid patients and another process for non-Medicaid patients. Questions? This is working now. Come to you. Okay.
So I was curious if you guys are using a walk-in model or if you're using just a scheduled appointment model or a combination of the two. And then what's considered a full day, I guess, like how many patients are you looking at when you're doing this analysis? Is it 5 patients, 10, 15? I'd be curious to hear which organization is the least or the most challenging.
Okay, so we do a combination of walk-in appointments. They're all our injection patients are med only. We try to have all of our city side appointment only if we can. And then we have been it's newer for us, but doing that walk-in. You know, patient picking up their prescription, well, they have a lot of questions about their blood pressure, about their diabetes. And just going a little bit more in depth with them, to where we can maybe put like a straightforward ENF code. SNDP code, so that's a little bit more on that kind of walk-in basis as needed. But we do try to have most of our patients on a appointment basis. We're at full capacity. I'd like to have like 12 patients a day. Depending on what the services are, injection patients usually about half an hour appointment or less. There's more medication reviews, maybe 45 minutes or an hour. So that could depend.
We do a mixture of both. So I'm walking some more in telehealth appointments. So they'll give me just a timing range, but for afternoon calls, just my person's study. So you know, and the other is I'll work in setting visits on the site.
So this team of pharmacists, even before provider status, essentially set up like providers in the clinic, and so they have schedules very similar to the APPs and physicians in the clinics, and they are held to the same organizational expectations as the physicians and APPs in regards to kind of their schedule, their capacity, their fill rate. But we look at a variety of different factors to understand truly how successful each pharmacist is being, with the primary focus being on clinical outcomes for their patients. But also patient experience through surveys, and we also look at kind of patient panels, volume, and also how quickly patients are being discharged from the process. So it's a multi-factor instead of just number of visits or number of patients per day.
Yeah, similar to Jordan, all of our visits are scheduled. Prior to implementing provider status, we had our own schedules, kind of similar to other providers in the next space. We tend to get referrals for patients who are fairly medically complex and have a lot of social determinants of health. So most of our visits tend to be an hour, and so then the day goes up pretty quickly because there's a lot of health literacy concerns that we're working through, or a lot of different medication disease state things that we're managing all in one visit.
I think we could be in one really quick question if someone has something to get a chance to ask.
I don't have a question, but I just want to, I mentioned it earlier, when I was talking about how. There seems to be some rules that when it comes to billing. And one of those rules that I cannot build on the state that inpatient see the plan. So in those circumstances, we have started doing more trade-offs. So I would say, you know, you'd be a great candidate for a bubble package. Let's have you meet with pharmacists to, if that's right. So I'll go with the group, I'll explain to them our expenses, but I then a different day. They probably didn't bring them in anyway. But a different day that would come in, sit down, and that's when we hear about really. For those. Day.
Is there any, I know we had some other things we could have talked about. Is there any last moment bits that anyone didn't get to say that they were really hoping they would get to share with the audience before we wrap? Okay. Okay, well, if you stick around the next hour, there's going to be some cases that really help you walk through how to do billing. There's some more intro cases and then some complex cases. So no matter where you're at, there's going to be something for you. So stick around for that. Just to do our oopsie. Oh, did I jump extra slide? I think. Hold on, let me make sure. Oh, no, that was it. Okay, so there are a few Slido questions for the just the review for this session. So here is the first question. Which of the following best describes a common challenge associated with implementing pharmacist provider status in ambulatory care, community, and FQHC settings? And it looks like there we go. Most people, I'm going to go quick because we don't have a lot of time. My notes, of course, are on B and C, I believe are the correct answers. But of course, I don't have my slide notes and I didn't know these were going to end up in Slido. Oh, my goodness. Okay. Yeah, it was Carrie in the background telling me which one's right. The next question, true or false, health systems may require more lead time than community pharmacies to implement pharmacist medical billing due to the complexity of aligning infrastructure, privileging, and credentialing and interdepartmental workflows. So we'll see some votes coming in here. And yes, true. Very good. Final question. Which of the following is the most effective first step for a pharmacy organization seeking to support pharmacist-led clinical services through sustainable workflow design? Hiring a billing specialist, eliminating tech roles, conducting a workflow assessment, or applying for a grant? Okay, so far, yep, conducting the workflow assessment. Perfect. All right. So with those, you'll know how to answer your CE questions at the end. So I'm going to show you all that Lecture Panda CE code right here. And I really appreciate the panelists' time. It's been a lot of work of PSWs to make this happen, and a lot of experts in the state together with PSW to make this happen. And so it's really exciting to see where we've gotten in the year, and I can't wait to hear what another year will bring. So thank you all for being here and for all of you in attendance.